Welcome to this webinar, Meeting IAPT Access Targets with Effective E-Triage, brought to you by SBK Healthcare and sponsored by Limbic. To find out more about our further educational podcasts, webinars and forums, please do visit our website at sbk-healthcare.co.uk. In this webinar, you will hear from Dr. Gisela Unsworth, a Clinical Service Manager, and Jacqueline Rose, also a Clinical Service Manager at Surrey and Borders Partnership NHS Foundation Trust, joined by Dr. Ross Harper, the CEO of Limbic. He will be in discussion about how Limbic's digital tools have supported their triage pathway. I am really pleased to welcome Ross Harper. He is the CEO of Limbic and he will be kicking off today. Hello, Ross.
Hey, I'll take it from there. Thanks, Vanessa. Hi, everyone. As Vanessa said, I'm Ross. I did my PhD in computational neuroscience at University College London, and I'm the CEO and co-founder of Limbic. So a little bit about Limbic. We're a team of clinical psychologists, computer scientists, and software developers. And we're really on a mission to bring the latest AI technologies safely and responsibly to NHS IAPT. And I think that's a big part of our company DNA. We're a UK organization and we really do build specifically for IAPT. We believe in this care system. It's fantastic and it's unique and it deserves its own solutions. And so we wanted to try and do something to deliver them for you guys. So we've created a number of tools for the IAPT care pathway, including a mobile app to support patients while they're on the wait list and during treatment. But today, we're going to focus our attention on a triage solution, Limbic Access. So, we've got the next slide. So Limbic Access is the leading AI assistant for triage and assessment support in IAPT. We're really, really pleased to have won a number of awards and have been named by the NHS as a high-impact digital solution to optimize IAPT service delivery. The system is currently available to over 9 million people in the UK, and we've released over 20,000 clinical hours for IAPT so far. So we're really thrilled to be a part of tackling some of the challenges faced by IAPT currently. Now, as a widely used triage tool, we really wanted to make sure that we meet the highest clinical and data governance standards. So I won't go into everything that we've done, but we're really proud to be a UKCA marked medical device, and we've achieved our ISO 27K accreditation, among a number of other things that we won't dive into. So I think that's it from me. I'd just like to thank our supporters, really. So firstly, we're on the Digital Health London programme. We're supported by the NHS Academic Health Sciences Network and Innovate UK and Horizon 2020. But importantly, I think really a massive shout out to all our partners in NHS IAPT around the country who've innovated with us to the benefit of staff and patients. We're really pleased for the ongoing support. So now I'm going to introduce one such partner, Mind Matters IAPT from Surrey and Borders Partnership NHS Trust. We're going to hear from two clinical service managers, Jackie Rose and Gisela Unsworth. Jackie and Gisela have both been in IAPT for a number of years, and I can say from personal experience that they're both extremely passionate about patient care and using technology to improve IAPT service delivery. So Jackie and Gisela, over to you.
Thank you, Ross, for the introduction. Okay, everyone, so thank you very much for coming here today to listen to how Limbic have helped Mind Matters reach our access targets. So myself and Dr. Gisela Unsworth will be talking today about Limbic and how we've used that within Mind Matters. Next slide. So a little bit about Mind Matters. So we're an improving access to psychological therapies IAPT service. We're one of 5 in Surrey, and jointly we serve a population of just under 1 million people aged 17 years plus. In the years 2021 to 22, we received just over 14,000 referrals, and that makes us one of the largest in Surrey. And it also poses us with a few sort of problems to overcome. The next slide, Gisela. So we were looking at a digital solution that was going to help us meet the NHS long-term plan, which is to increase IAPT accessibility targets by approximately 380,000 people a year. That probably would be across the whole of Surrey rather than just us. And also we were looking to improve the assessment process and the referral process. Our aim, was to reduce the admin burden. And, you know, we also are aware that the initial assessment could be quite labour intensive for clinicians. And across, you know, the whole of IAPT nationally, at the moment, there is a shortage of mental health clinicians, and across all services, generally the stats have been about 1 in 10 posts are vacant. Next slide, Gisela. So the process before Limbic was that the patient would refer in, then they wait, and while they're waiting to be contacted within a few days of referral, the admin team would check suitability. They would make sure that all the data have been submitted for NHS number and all of those things correctly. And then they would contact the patient to book them in for their assessment. And again, there's another little wait for that. And then at that assessment, as with all IAPT services, they would be assessed for suitability for the service and the right type of treatment. Next, Gisela. So the way that Limbic can help is that it assists the referral and it also screens automatically. So it's a really engaging, friendly little Autobot. And what our admin team have discovered is that it will screen out unsuitable referrals, and it won't just screen them out, but it will guide them towards the correct service for them. So if somebody was underage, under 17, they would take that person and then lead them to the right service for them. Or maybe if the person was out of area, they'll be taken to the correct NHS webpage where they can find out, you know, the right service for them. It also checks the NHS spine, which is really, really helpful. It can also book in appointments, but we don't use that currently. And it collects data. The other thing is that because it engages people, people are less likely to drop out. And if they do drop out after a certain, I suppose, stage in the referral process, we still receive that referral. Whereas if it was an online booking form, we would lose that. The other thing it does is, as Gisela will go into more detail in a minute, is it looks at risk. So those are flagged up early. And it's really, really helpful in that it will email people, you know, sort of like a book about the service at the end of their referral, and that's really, really helpful to us. It means that people kind of know what to expect and so on. So then the referral comes into us, and it's more likely to have the correct data. So this is a little example using Ross as a demo, and it shows you how Limbic works. And it's really, really clever. And I'll just let that play through to the end, just so you can have a good kind of grounding, you know, for how it works and how it can be helpful. The other thing to mention is all of the registrations that Limbic has. As Ross was saying, you know, it sort of meets all of the requirements of the NHS. So when that's finished, Gisela will move on to the next slide. So next slide. So this is our website homepage. And as you can see, Limbic, it sits as a little pink friend just down in the right-hand bottom corner. And if Gisela clicks to the next slide, you can see how it will automatically pop up and it catches people's attention. It invites them to refer. And the other really good thing about it, if Gisela clicks to the next slide, is that what happens, it goes into a full page if you're on a desktop. And with that full page, you can opt out and you can use our standard form if you want. But what we've noticed is that people don't tend to do that. They stick with Limbic and they report that it's really, really helpful because, you know, it helps sort of them find their NHS number, it helps them find their GP and so on. And the other thing it does as well is it will screen out for risk. So it offers those people who are in urgent need of help a link so that they can opt out and get the right service that they need right away. So that's all for the kind of first part of the referral. I'm going to hand over to Gisela now, who's going to talk a little bit more in a bit more detail about how we set it up and, you know, further benefits of it. So over to you, Gisela.
Hi, everybody. Hope you can hear me okay. Thanks, Jackie and Ross, for giving the intro to this very exciting product. So IAPT is incredibly engaging. I mean, it really is, it's not an exaggeration, a friendly digital assistant which supports referrals and assessment for IAPT services. We know that patients have given me feedback to say that they've used other kinds of like utility companies, chatbots and all other different ones, and they're really boring and they get frustrated with them. But they found that Limbic was really, really friendly. So I can, you know, vouch for that based on what they've said and their experience. Also, it assists with referral, as Jackie showed you there. It guides you into the web page and it gives you the option to go all the way through. So you can do like a standard one, which collects everything in about 5 to 6 minutes, or you can do a more in-depth one where you can go on for a few more minutes and get a lot more data. And it asks permission all the time. Do you want to carry on? So it depends on how people are feeling. Obviously, the static form is still there, as Jackie said, as an option. So if people don't want to do the chat and they just want to click, you know, like we used to do for years before, online with the form, they can do that as well. So it doesn't exclude people who would prefer that as well. In terms of admin support, Limbic does signpost these unsuitable clients, and I will show you some stats later, but it's quite a considerable amount of time is saved from admin not having to contact people out of area and find out where their local IAPT is with phone numbers, etc., and underage patients. So it saves an immense amount of time to admin on this. The other thing, it helps all of us, and Jackie and I still run small clinics each week. So we see patients, and we also undertake telephone assessments. So we are very much aware of exactly how this is benefiting the clinicians. So it supports in completion of the IAPT MDS, the minimum data set, and screening patients for common symptoms. Now, what's really fascinating is that Limbic in the referral bit that we see when we're doing the initial assessment, it says there whether it's a primary issue, for example, it says it's depression, or whether it's anxiety. So Limbic will give you a bit of a spin on, based on what somebody's answered, what it is. Then as the clinician, this will help you to sort of hone in, but I'll talk a little bit more about that in a moment. Now, this other factor is quite interesting, interoperability, because data is shared with all of us via major IAPT systems. So it doesn't matter which system you use, there is compatibility so that it can be adapted. Limbic can adapt to all different systems because not everybody uses, you know, a certain one. And I think that's a key factor as well. The one that Jackie mentioned, which is risk management, is one of the facets that I love as a clinician. Now, Jackie and I, plus some of our other seniors, do like a daily senior risk duty management on the day. And what happens with IAPT is, because it's loaded up and designed so that people are assessed for risk, and if they're too risky, they will be, you know, shown where to go for the crisis services, so that referral won't continue. and it'll direct them what to do. If they are some risk but not too risky, automatically it sends out a keeping safe in crisis leaflet with all the crisis numbers should they deteriorate and so forth. And then what happens, doesn't matter what time of day and night it is, it sends us an email, but we only respond to it Monday to Friday. So when we're on risk duty, first thing we do in the morning is look what's come through as a priority one. So we will make sure that our admin team will upload those people, and our PWP senior on duty will do a risk screening call to those patients that are deemed sort of higher risk, as it were. Obviously, if they're too risky, they wouldn't have carried on in the referral, but the ones that are, we're alerted to, so we can prioritize them right away. So that's really, really helpful for us to zone in on dealing with risk. Accessibility, well, because it is available 24/7, it just means that they can engage people in finishing off the assessments anytime, you know, when they have that, the height of their behavior, you know, the help-seeking behaviors, which is great. I understand that, I don't know if I would have used it because I speak Portuguese as a second language. I haven't tested it out for the multiple languages, but I know that it's in the software, and it's also optimized for the visually impaired. So that's really, really fascinating. We also have had some really interesting and exciting challenges, quite a steep learning curve for Jackie and I and our clinical lead, Dan Brown, on how to implement this brand new sort of technology into our systems, into a core NHS service. And we did invest £75,000 for this. And we know that Limbic is very, very much suited to us. So as we were learning, it was iterative learning. You kind of get feedback from admin, from clinicians, you feed back to Limbic, you say, this is what we wanted to do, we're not quite happy with this or whatever. They will tweak it so that we get a system that's actually custom made, you know, for us, and exactly what complements and supplements our triage pathway. So it can be made unique to whichever service it is. So we've created this implementation team, which included the three that I've mentioned, Jackie and I and Dan. We met very regularly, like weekly. We had to work all very collaboratively to deliver this improved service, also with a lot of partners within our own organisation, which is a wider mental health trust, to be able to integrate this into our own patient management system. So we are the first NHS trust to implement the system. So there were quite a few multiple steps required to get this through the line, as it were. And I've kind of jotted down what some of these are because there was quite a few. So for example, well, the one that probably most managers will know, the DPIA. Yep, that was one of them. DPIA is really, really important. But what we also learned is that our digital partners within our trust are absolutely brilliant at knowing more about this stuff than we do. So they would guide us as a project management team office into all that needed to be done, including clinical safety cases and so forth. And so the good news is that because we've gone through all of this, we're very happy to share, you know, our learning with individual trusts, and including documents that we will anonymize, etc., for use by other trusts. I think for us, that was one of the things that we wanted to share with you all today, is that you don't have to go through alone should you decide to do this. We can certainly support you with some documentation, which is what we found tricky to get it all together for the first time to meet the stringent requirements of NHS governance and so forth. And of course, there is a new NHS IAPT adopters, which are welcome to use the playbook for our implementation. That's been done. Limbic, you can reach out to them and they will be able to share that with you should you wish. And it's just got a little bit more detail about our implementation. So if we just go through this pathway, so you can have a little look at what it is. You've got your whole technical side, compatibility with our patient management system, depends on which system you're using, but usually it's compatible, just a few tweaks may need to be done. You need to agree action times and deadlines, demo delivery, and then you get onto the operational side, customizing the user journey. And this is where we went backwards and forwards to make sure that we were happy with it, and our patient feedback and so forth. And then it was signed off on the risk management side and accessibility. Then a huge thing is to get your staff on board as well. It's all very well having the theory of it, but then it's facing all the questioning and then trialing it and seeing how it works. So the onboarding and training of staff is absolutely key element to be able to get everybody on board. And then there was the setup, so test demo, version on the service website, and then you get your final feedback round and iterations. So it sort of goes round, and it's Limbic have been so patient with us. It's amazing because at the end of the day, I'm not very technical, and Jackie's probably better at it than me, but we've had to have Limbic's help, and obviously the our digital office as well. And the final one, my eyes are not very good there, bespoke analytics dashboard to monitor the real-time insights. Now, Jackie's used this more than myself, but what I've seen of it, it's absolutely brilliant. So it has a dashboard where you can, everything flags up, you can check what are people saying, that's your patients, how do they feel about the service so far, etc. It's all, you know, we get all that feedback, what time of day or night are they accessing the service, we can get all that data, lots and lots of things as well from them. Of course, you still have to keep weekly meetings so that you know exactly what's going on. We are currently being evaluated by an independent part of our organisation looking at Limbic, so we are producing some information for them. So it's really important to keep evaluating when you have something new like this to make sure that it's really meeting, you know, your needs. So the benefits of the Limbic E-Triage tool from a trust level, I mean, we've actually seen 30% increase in referrals. We know that the national target is around 25, and we know that nationally IAPT is not meeting, hasn't met that 25 in the last financial year, but we exceeded that and went to 30% referrals. And we do believe that that's hugely contributed through Limbic's usability and ease of use to engage patients. So the platform has been really used to deliver against NHS targets in a very robust way. We know that it's reduced the average time to complete an assessment by, 15 minutes. And within the first 12 months, we released around 3,000 clinical hours, which would be equivalent to around 4 PWPs. So if you think about how much they're paid, you can see that, it really does cover, our outlay, initial outlay. Also, that 20% of additional referrals are actually being signposted. That's work our admin didn't have to do, have been signposted out, which is really important for the trust because there's a service up north that's quite a similar name to ours. It's quite helpful to say you're in a different part of the country, for this service, you need to go up north, as it were. So the final point on this slide is the Limbic chatbot has helped increase capacity and had a positive impact on improving staff wellbeing and retention. This is really, really key, and I can't underestimate this. Jackie and I, have been doing it and speaking to our clinicians, and we know that although we only do the odd TA here and there, the assessment, we know that those are doing back-to-back TAs, and nobody, I think, ever does more than 4 or 5 in a day. I would imagine, because when I've done maybe 2 or 3 in a row, it's so much easier having done it the old way, where in the same time I had to gather everything and then give the patient time to explain their problem. This way, it's kind of all gathered, all the demographics, and then I could just zone in. So for my mental health, and I only do it a little bit, I can really see that it's so beneficial. Never mind the PWPs that are doing it all the time. It really cuts back, and we haven't increased their number of contacts. So what we've done, it's a real bonus for them. They get all this information, they have reduced time, and they have that for their well-being so that they can spend it having a really good session assessment with the client. So the benefits of Limbic E-Triage for patients, well, look, it's so overwhelming. 98% have actually given feedback that it's helped them to access care, and only 1.9% have said that it didn't help them in the way that they, we wanted, or that they felt that it should have done. But you can see that 98.07 is overwhelmingly positive. There's quite a few patient quotes that we have, but I've just put one here. They said, "It's a kind and gentle process. I was anxious about seeking help, but it was easier than I thought. Thank you." And what I have found, even though they give this feedback digitally to Limbic, when Limbic asks after they complete the referral, when I do the actual assessment with them, I ask them as well, "Thank you so much for completing Limbic." And then I ask an open question, "How did you find completing it?" And then they'll give me their feedback. And sometimes we have a giggle, the patient and I, because they said, "It's so real, I thought, should I trick them?" Their patient said, "Or should I lie to them?" And then I thought, no, when I get assessed, I'll probably get found out, so I better tell them the truth. So it's really quite funny, but because it's so realistic. And so when we think about how patients feel, that makes us happy as clinicians, that their majority are really, really happy to users as a tool. So we want you to talk to us because, you know, Limbic are sort of using 20% of all IAPT services there, have thousands and thousands of patients, not just from Mind Matters, but just one small service compared to the experience that they have. And so Syed, you know, from Limbic is ready and willing to set up and arrange a demonstration of how and what it could do for your service, which I would recommend, because we sort of went into it very excited, and we're still super excited about what's next. So it's over to questions. Oh, just one last one comment. This is really, really important. This is from a PWP, Adam, who has always got excellent feedback. He says he completes most of his assessments in 30 minutes instead of 45 minutes. Limbic means that he can focus on how best to support the client without worrying too much about information that he's missed, but he can still use the referral to clarify details such as primary presenting problem, medication risk. He says it's a richer discussion. I agree with that word. It really becomes richer with the patient and the patient goals and the next steps rather than feeling rushed. I know that when I do an assessment, I literally look at 5 minutes before what they filled out, and I assure them after they've given me feedback on using Limbic, I said, because you've done that, it's gathered so much information. I know you've got 2 children called, you know, Dan and Benita, and they're 6 and 3. And, you know, you give the key things, and I'll say, what I want to ask really is, are you still on the same dose of, you know, medication? You've had previous treatment, you know, what was helpful, what wasn't, what are you looking for this time? You can really zone in on what the issues are, you know, to those that aren't virgins to therapy and the ones that are, to sort of explain more to the ones that have never had treatment, don't know what to expect and what we might be able to offer. So I've certainly, alongside, as you can see, Adam and other PWPs are blown away by the quality of the assessments that's increased and improved as a result of using Limbic to help our patients increase access to us. Okay.
All right. I think then it's my job to maybe chair some questions with Gisela and Jackie, if everyone's okay with that. Thank you so much, Jackie and Gisela, for sharing those slides and talking through it to your colleagues. So I will go through some of the questions that have been coming through in the Q&A. I've got one here from Paul Reed, which says, as your service is not using the automatic booking side of Limbic, I expect this means that admin will contact and agree appointments with clients. Is it as basic as that? Maybe Gisela or Jackie, you could talk around the process of how an assessment is booked in after someone comes through Limbic.
Yeah, sure. I'm happy to do that. So currently, we don't need to call our patients because the system that we use the auto booking through that at the moment, although in the future it's hoped that we will move over to more of an automated booking, a bit like you know, sort of Limbic offer, which I think it sounded really good, Ross. Maybe you can tell everyone a little bit more about how that works. It would be quite helpful, I think, everyone to hear.
Yeah, sure. So if I just take a quick step back, the goal of Limbic Access is multifaceted, but one key thing we want to do is save service staff time as well as boost referrals, because, you know, there needs to be these competing forces to offset. Otherwise, the service could become overburdened while trying to achieve access targets. So targeting the administrative components of a referral, we look up whether or not their GP is in the catchment area. We can also look to see whether they're at the right age threshold, and that's variable for different services. And we can also use any other eligibility criteria provided to us by the services to potentially signpost people elsewhere and save the admin staff the time of receiving a referral and then having to call out to explain that this particular user is in the wrong place or it's not appropriate. So we get the user to the right place quicker, and we also can save admin staff time there. with regard specifically to the appointment booking, Limbic has the capacity to read available slots from the patient management system and present these to the user in the chat window there and then while they're engaged, so that they can choose their appointment. Not all patient management systems support this, but there are some IAPT services, I believe, who are piloting this direct booking feature currently, and it's very much something that we're going to push and develop further. Okay, so I'll move on from that question. I've got another one here from Beth Sear, which says, are there standardized unsuitable patients only, for example, age or out of area, or can it be adapted depending on the suitability criteria of your IAPT area? So I think that's partly what I was just saying there. Yes, it is GP, registered GP, it's age, that is variable, but you can also provide any other eligibility criteria that you would like us to build in at the front there, just to make it specific to the IAPT service. Anything, Gisela or Jackie, that you wanted to add at that point?
I was just going to add actually that Limbic's been really helpful, because where our criteria have perhaps changed, so when we switched to seeing patients who were under 18, you were able to change your screening process to match what we needed, and I thought that was a really good benefit to us, for you to be able to just switch in that way.
Yeah, I was just going to say, just based on the conference I attended, the IAPT conference in Birmingham on Wednesday, I also, it was sort of raised by Hayley Matthews, are these technologies able to, for example, in future, put whatever a service wants? So if we want to screen out eating disorders or whatever, so the potential is there for services to follow the IAPT standardized protocol, potentially to do any of this, but we have just sort of trying to get it on board first, made it as simple as we can. But of course there is that potential, which is quite exciting for me to hear that, because otherwise people could be potentially knocking at the wrong door when really they need to be signposted to eating disorder services.
Excellent. Thanks, thanks Gisela and Jackie. So trying to choose another question here. Can Ross talk about more user feedback at a national level? Yes, I mean, in short, the user feedback that Gisela covered there seems to hold at the national level. So the last time we ran an analysis, we'd had over 70,000 patients had provided feedback in the chatbot, and around 98% or thereabouts had said yes, Limbic could help them access care. 90% had given us the absolute highest score, and around 7% or 7 or 8% of that 98% had given us ideas on how we could improve, which we're constantly trying to build in and iterate on, and we're doing that in collaboration with our IAPT partners. So that's the feedback at a national level, but I guess maybe it's not necessarily an exciting response, because it's exactly what Gisela went through in her slides at a more local level. A quick question from Rachel Wall, and I think this could be a good one for Gisela or Jackie. Do you have any duty system triaging the referrals, or does Limbic do all the triaging? So maybe we could talk a little bit about how risk is managed.
So we, when we talk about the triage, it doesn't count as an assessment. So services are different in the country. So ours is assessment, and treatment is when we enter treatment, and we have to meet that the six weeks for that. So for us, in terms of the initial, what Limbic does, it does the screening of risks. If they're too risky, it directs them to a crisis service. If they've got some risk, they'll send the staying safe in crisis and a crisis leaflet that we've asked them to do, and also will simultaneously alert the duty person, which is run Monday to Friday. So if they're too risky, they just wouldn't go through to us, because it would just be, they would be asked to contact the crisis service that IAPT is inappropriate, for them at that time. So I don't know if that answers the question, because we're talking about risk. I think I explained it earlier, is that then we would follow that up with risk on the day, most definitely as a priority, so it flags that up. So it would be done at the latest. If they did it, you know, on a Friday night, it will be Monday morning, first thing that will be dealt with. And there is a disclaimer to say, you know, that this is, you know, responded to in normal kind of working hours for risk. Yeah, that somebody will be in touch.
Excellent. So I've got another question here from Julie Tran Graham. She's saying that she'd love to understand the main demographics of those who use Limbic to access your service. So again, over to you.
My understanding, and we are actually going through a good evaluation now. I'll probably in a few weeks' time I would have the answers to this with statistics. But my understanding so far of what I've seen is that they pretty much reflect, you know, what we used to get before, except what is fascinating, and I have evidence through something else, which is through paying interpreter fees, is that we've tried to reach out to those from ethnic diverse groups, is that in the last year, we've increased our bill, because I authorize the payment of, by 4 times for interpreter fees. So yes, that does reflect the 30% increase, with also BAME population increasing, but also using, you know, through Limbic, which is the main way that people are coming through. So we're able to reach those populations. And just to assure you that for those people who are unable to use Limbic, for whatever reason, they can use a static form, or they come in through a healthcare professional. So if they're a really elderly person, whatever, they will go the normal way, give us a phone call, or their relative will, and we'll take the referral in another way. So we'll make all those reasonable adjustments so that nobody, you know, misses out on accessing, you know, an IAPT service, our IAPT service. So I just wanted to assure everybody that that still goes on as a dual process, but the far majority have become, even older people, more tech savvy. They've had to in the last 2 years, you know, their children are really supporting them, or relatives, to access this type of thing. So that's all very exciting.
Yeah, that just on that point, Gisela, it's been an interesting finding from our point of view at Limbic, because our initial hypothesis was that this might appeal more to maybe younger demographics, but actually we are not seeing that in the data. And there's an opportunity for us to collect some qualitative feedback at the end of the referral process. It's optional, but when we did thematic analysis on that, we found that across demographics, we're seeing the same sorts of patterns, which are that they're aware that it is a robot, but it is friendly, it's engaging, it's kind of naturalistic. And so it allows them to 24/7 complete a referral, or sort of begin this process without that activation energy of having to find a quiet place during working hours and pick up the phone and speak about sensitive thoughts and feelings to somebody else on the other end of the phone, which I think can be a little bit of a challenge there. So that's just a finding that we had on our side from looking at the data. We're also joined, by the way, by Dan Brown, who's a clinical lead at Mind Matters. So Dan, whenever you feel relevant, please jump in and share your 2 cents. So I've got another question here from Lynette Medzima. How does Limbic support patients who may be computer illiterate? Is there an option to support such patients? So I can kick off just from a design perspective. So we developed Limbic against internationally recognized standards for the visually impaired and blind patients. So that was a big part of our design process. We do limit typing, and we try and make sure that it doesn't become too off-putting in terms of like multiple questions just being front-loaded up front. It does it in this sort of chat way, which is maybe a bit more accessible. And then I think really it's kind of goes back a little bit to what Gisela and Jackie were talking about in terms of seeing that increase in referrals and being able to sort of smooth the conversion from visitor to referral at that point. With regards to future developments, we're constantly looking for ways to try and make Limbic more accessible. Equity of access is a big part of why we built this thing. So it's always on our agenda, and we look to services for feedback on ways that they think we could improve.
I was going to add, Ross, that from my observations, it works really well in offering people kind of the choice between certain things. So like ethnicity, it'll give you the choices and you just select the one that suits you. So it's much easier than sort of tick boxes or having to fill in loads of empty boxes with information. And there's minimal sort of, like you're saying, typing involved. And so in that way, I think it makes it really accessible for anybody who could navigate the internet can complete a Limbic referral. It's much quicker and easier.
Thanks, Jackie. So I've got another question here. Do patients who are signposted out, so this would be at the eligibility criteria point, do they count towards the access target?
I think Jackie can probably answer this best. My understanding is that people count towards our access targets once they're on their system as a referral. So if somebody is on our system and is then, for example, signposted out through our standard processes, then they count towards access targets. If they're signposted towards other services at the point of entry before we gather that data, obviously we can't add that data into our targets. Obviously, once we have access data for people, once we have their personal information, we have a duty of care towards them. So it's very much at what stage of the process is the short version. If somebody come from, say, Sunderland, calls in looking for treatment, we will direct them to the Find Your Local IAPT service page. That person won't count towards our access targets. But I think once somebody is in the system and then after conversations with clinicians, they may be signposted elsewhere, then they would, I think. Jackie, tell me if I'm wrong, I apologize.
No, Dan, you're absolutely right. But, previously, before Limbic, everybody came in as a referral and our admin team would have to sift through and filter out all of those who were unsuitable, signposting them to the right service. And so, all that proportion of their work is done for them. And those people would have in the past counted as referrals. But now with Limbic, sifting out all of those people, as far as I know, everybody coming in would be eligible in terms of area and age. So it does save a lot of time, but it also means that those people have been signposted to the right people before they go through an unnecessary process. So it's a better sort of user experience in that way.
Yeah. There's nothing worse than filling out a massive great form and then being told, oh, not for you, sorry. The sooner we can do that, the better for the person referring themselves in.
Definitely. So we've got a question from Beth Sear again. Do you get any pushback or feedback from patients who may be resistant or nervous about trusting AI or robots?
Not that we've seen so far. Obviously, I'm not sure if you guys have shown the quantitative data on sort of preference of use yet during the slides. I think you probably have, Ross. We are doing a really thorough evaluation where we're going to really do a deep dive into not just the feedback through Limbic, but also our assessment PEQs, patient experience questionnaires, to see what comes up through those. At this stage, not really. I think for those that try it, it's open. So it says, well, this is a bot, which is good. And we give people the option of not using the bot if they prefer. But actually, it's a really easy to use system, quite frankly. It's much more pleasant than wading through a form in my experience. So the short answer to your question, Beth, is not as yet. Obviously, not everybody 100% likes the process, as you would have seen, but vast majority do. We'll be able to give more information on that once the qualitative full evaluation of our partnership is complete. Hopefully that answers your question.
Great, cheers, Dan. So I've got a question from Lauren Bland. So this tool looks like it would also be very helpful for non-IAPT services. Is there any scope for multiple services to be linked to Limbic to allow for a more centralized access point style bot triage assistant?
Would you like me to answer that, or Ross? I know that you've been in conversations with the trust about that as well.
Go ahead, Dan. Go ahead.
Okay, this for me is one of the most exciting things about Limbic as a system. And it's something that we have actually approached the trust about. And in fact, it's one of the reasons that we got funding for our initial pilot at the early stages a couple of years ago in order to do this. As most people on this call will know, that there is a move within the NHS 10-year plan to move towards a single front door. And a service like this can be incredibly useful. I actually had a conversation with some people from NHSE about this as well, and they were asking the same question. So currently, we can use the bot to signpost to the appropriate service or the appropriate website, this sort of thing. We do that as early a stage as possible so that we don't end up gathering all the information and then having to repeat it. With regards to integration, though, we are looking potentially, and the trust, SABB as a trust, are looking at the benefits at the moment of working alongside Limbic to develop a system that works across all of our access pathways. So the incredible thing about that would be, for example, if somebody were to refer themselves into Mind Matters, without saying, the worst thing is when people come in and say, oh, we're not for you, go somewhere else. So the ideal thing would be if, for example, we were linked in also with a single point of access for secondary care. Instead of saying, go here, we could just continue the questioning process and tell people, look, it seems like, this other, our secondary care services might be more relevant to you at the moment in helping you to stay safe or getting the treatment you need. We'll continue to ask some questions on behalf of them instead. So it will, that open door, no single door, no wrong door is absolutely, I think, at the heart of what these digital front door services are about. And I know that it's very close to Ross's heart as well. So the short answer is yes, there is scope to. The slightly longer answer is it's something that continues to be in development, and we're hoping to enter into partnership with Limbic to really develop that in the most robust way possible. Because there are obviously sort of things like connections with, are we using System 1? Are we using IAPT? Are we using PCMIS? Are we using the range of different electronic providers? So it's a program of development rather than something we can just drop in as a tool right now. But in principle, absolutely, it's very, very exciting. It's one of the things that most drew me towards the partnership with Limbic in the first place, I have to say.
Yeah, and we are committed to trying to push that forward as well, because as Dan said, right, it's really close to our mission and why we're doing what we're doing at Limbic. And it's an opportunity because our system is able and has been built in a way to interact with different care, patient management systems, different health records. We're linked in with the NHS Spine. And so we really just want to tie all that in the background and just really drive home this idea of there is no such thing as a wrong front door. Wherever you go to seek help, you're going to get the right support for you from that point. Yeah. Okay, so I've got a question here. Can you talk more about accessibility and improving access for marginalized groups? I'm not sure who wants to take that one.
I think Jackie or Gisela can probably answer that from sort of a systems perspective as much as I. So go ahead, guys.
Do you want to go, Jackie?
Gisela, I mean, you might know about more the way it might be able to translate different languages, or
vulnerable. Yeah, I mean, basically for a lot of the marginalized groups, they can get support, and so that would come, other people would help them to fill in another way if they haven't got the ability, let's say, or the presence of mind or the wellness to have a conversation with Limbic for 5 or 6 minutes or whatever. And they just cannot even face a static form. We will support them, and that will be making those adjustments that I spoke about earlier. That would be either through their professional referral or relative in through with us, or our admin team to do that. But of course, that's the minority now. We used to get a lot of that before, but a lot of people have now been directed to it, and they can take their time with it. And so even with ASD and LD, we haven't, I know that this thing there from Eliza Pepper one on the questions, we haven't had any adverse feedback because we always label them up, so that we see, I've seen people with LD and ASD who've been through Limbic, and there hasn't been anything untoward, in terms of feedback given about that process. So I mean, it's still all learning. It's not quite a year, so we'll see. But so far, no major issues have come up, thankfully.
And I think that will be part of the evaluation when we look at the qualitative evaluation as well, because Limbic's able to help to identify things like learning disability and neurodiversity. And short version is we'll be hopefully within the evaluation we'll be able to pull more of that data out and really make sure that we're providing the right service for people. One of the other things that we are doing is that I've had communications with people from the Learning Disability Service and also service user groups, and we are actively making progress and looking at ways in which we can best make the system work and let's make our pathways, whether it's through Limbic or any other entry point, work for all people from all ranges of the community. So you've talked about different languages already, but in terms of neurodiversity, in terms of learning disability, literacy, all those things, accessibility is really important. It's something that we're working towards. It's never going to be perfect, but it's something that we keep having to, we keep choosing to try to work towards with regards to experts, both through practice and experience.
And I think, Dan, as well, to add that because the bot is quite chatty in that it talks to you as if a person might, it's much easier to complete the referral because it has very short kind of sentences. It asks really short, concise questions, whereas some, perhaps for some people, a form might be harder to complete. And so actually doing the referral is much, much more accessible.
And I think, I'm not sure if you guys talked about this during the presentation, and stop me if you have, but actually in terms of out of hours access, I think that's really important as well. I think one of the things that drew me towards this kind of system originally was a lot of people, when they are looking for help, is in the middle of the night, or is if they're up at night worrying, and when we're like that, we might Google help in Surrey, whatever it happens to be, for anxiety, and it brings up a website. If that website then brings you to a thing that says, right, fill out this massive form, I can't speak for others, I personally would say, I'll do that tomorrow, because I'm not going to fill in a form now, I'm too stressed or I'm too tired. And it may not happen. Whereas actually with Limbic, it's such a smooth pathway in terms of asking questions, it's gentle. And I think that actually leads us to it leads to a much easier pathway at the time of need for people. And I was looking at the numbers just recently, and unfortunately I don't have baseline numbers for before we started using Limbic, but within Limbic, I think a third of referrals that we've received through Limbic have been outside of classic 9 to 5 working hours. And that to me seems like a really large number. As I say, I don't have baselines for that, but I was, anecdotally and, subjectively speaking, I was very proud of that. And I think that that's something that the system really helps us with.
Sorry, Gisela.
Go on.
Oh, I was going to say, I had a look on the dashboard that Limbic provides, and I was really surprised to see, 2, 3 o'clock in the morning, we're still receiving referrals, and you can see on the dashboard the time that the referral is completed and submitted, and the time they start. And so it just goes to show, that it's all happening out there, and
absolutely
it means that, like you say, Dan, that there's still this sense of there's someone there to listen.
Absolutely.
I was just going to say, somebody's asked about I'm just mindful of the time, the best sort of the benefits outside of the improving the triage pathway. And I would say a huge one for anybody who runs an IAPT service, recruitment and retention of PWPs is absolutely a massive issue for most services, to keep them on board and to recruit them. And I think we've had people come to interview going, I've come to you because we saw that you're really into innovation technologically with Limbic, we want to work for you. But also, with their mental health, what we find in terms of staff well-being, because the process is so much easier, the information is gathered for them, so they don't have to cover everything that's missing, and then go on and talk about and tell us how you're struggling and what can we do for you. They can just focus on you know, this is how you're struggling, what can we do for you, and this is what we offer, which could be more helpful than what your experience in the past and, you know, with other treatment that you've had. It focuses the conversation. So for the well-being of our staff, that's really, really key. And the quality of the conversation is richer from the patient end, because they're actually, you know, listening, being listened to, rather than being rushed through a series of questions, as it were. So that's a huge, huge benefit as well. And saving admin and clinical triage time, because people, you know, with the increase that we've had, over 30% of referrals, even bashing out 20%, you know, those that don't come in from out of area, you can imagine for us to keep up with this, we would have not been able to meet our 6-week target, I believe, if we didn't have Limbic, you know, helping us, because we just haven't been able to, you know, have the entire capacity to meet for that, to deal with it.
Absolutely. I think it's a combined thing, isn't it? And yeah, the feedback almost, and bearing in mind that this is a process that we have piloted and developed. So, you know, there's always kind of bumps in the road, and it's actually those bumps that help us to refine the service. That's a good thing. I would say the majority of the feedback that we've had from clinicians, as with people who've referred themselves in, has been extremely positive. Yeah, and we'll pick up on more of that in the evaluation.
There was a question on how many referrals are flagged to duty workers, because I know that was what we wanted to know. And we used to get a lot, and then we tweaked it. And Jackie can say more about that, and Ross. But in the end, probably 2, maybe 1 a day, sometimes maximum of 3 or 4. So it's gradually, you know, it's reduced a lot. It's manageable, essentially.
I think that's something briefly to mention. There is one, you know, there was also a question about sort of how would we change things, and the sensitivity of the risk triggering process was one that we really refined, that we really did think about. And I've actually run these processes through the trust. I've run them also through NHS England. They're very happy with the level of risk screening that we do at this level. The difficulty is that whilst it's not as catastrophic, an oversensitive risk screening process can be catastrophic to a service, quite frankly. So it's important to kind of get the right questions in there, and that's right for your level of service. Now, I know that Ross and the team, with regards to the handbook, they've done a lot of work kind of refining that with us and with other services as well. For us, our key thing initially is, can you keep yourself safe? If you feel you can keep yourself safe, we go through the process. If you're in a crisis, you can't feel yourself safe, keep yourself safe, we move people towards the appropriate service before they give us their information. We then ask PHQ-9 questions during, and then when necessary, risk questions during the process as well. And one of the advantages of a system like Limbic is that it only asks, we can screen out the questions that aren't necessary. So, it won't risk assess everybody. It will, do a full risk assessment for everyone. It will do full risk assessment for everyone for whom that is indicated. So actually what we can do is you can filter down to actually the people at most in need, as opposed to everybody who scores question 3 on more than one on the question 3 of the PHQ, question 9 of the PHQ-9, because that would have the effect of overwhelming managers and clinicians.
Definitely, Dan. And I think as well, just to mention for everyone's benefit, is that it kind of has a tiered process in that right at the outset, it does ask the person doing the referral if they're in a crisis, if they need urgent help now. So they're already screened out and screened towards the crisis line and the crisis services. But it then checks down at a later level about risk, and then if there is any residual risk that flagged up, then that it's that odd 1 or 2 that will come through to us. So we're not when we do the risk screens, we're not necessarily dealing with people who are in urgent help or in a crisis, but they're just people, for whatever reason, it's sort of raised those risk flags.
So there we go, it's 1 o'clock. Vanessa's joined us to tell us it's 1 o'clock.
I don't know if we've managed to answer all the questions, though. There might be some outstanding because they were coming fast and furious, weren't they?
That is exactly it, Dan. I am the timekeeper. I'd like to thank everyone. Thank you so much, Ross, for leading such a brilliant Q&A session. And of course to our brilliant speakers, and of course to Dan for popping on as well during the Q&A. I hope that you all found that as interesting and as useful as we did.